श्रीकांत सर नमस्कार. हेलो.
Very good morning, sir.
Good morning, sir. आज आपण सगळ्यांना मेल केलेला का मग आजच्या सेशन बद्दल?
हो सर,
अच्छा.
सगळ्यांना मेल पण केलाय, व्हॉट्सअपला पण शेअर केलेला आहे आपण.
Very good morning, Nilesh sir. Namaskar. So nice to see you on our platform. I hope
Good morning, sir.
The university officials will also join soon. We are just waiting for them. I just talked to Kaldas Chavan sir, Registrar of the Maharashtra Institute of Health Sciences, Nashik, and our university observer, Dr. Eknath Kulkarni sir. He is going to join very soon. As soon as he joins, we will start the program. Very good morning, Kulkarni sir.
Good morning.
Good morning, sir.
Okay.
Our guest, respected Dr. Neela Nimbarkar sir, is also with us. Shrikant sir?
Yes,
Shrikant
sir.
sir, can you hear me? Yes, we can start the program now.
Sure, sir. Very good morning, one and all. I am Dr. Shrikant Hadole, Vice Principal, Department of Dravyagun Vigyan, Jupiter Ayurved Medical College. I herewith welcome you all for this wonderful event related to cardiac investigative procedures through the Avalokan, day 3. This is a program which is jointly organized by Jupiter Ayurved Medical College and Tyrone Ayurved Hospital, Nagpur, and Rog Nidan and Vikruti Vigyan PG Association. Today, Dr. Nilay Nimbalkar sir will guide us regarding various radiological diagnostic procedures for cardiac diseases. So, I would like to invite respected Dr. Subhash Wage sir, the principal of our institute, for welcome speech. Over to you, Wage sir.
Thank you, Shrikant sir. Very good morning to one and all. This is our third lecture in the webinar series on cardiological investigative procedures. This program is organized on the occasion of World Heart Day by Jupiter Ayurved Medical College, Nagpur, and in collaboration with the Rog Nidan Vikruti Vigyan PG Association. Today we have a very distinguished speaker among us, Dr. Nilay Nimbalkar sir, who is also the brother of my friend, Dr. Prashant Nimbalkar sir. I welcome you, sir. Please accept our warm welcome. And thank you very much for sparing time with us. Another distinguished guest, as an observer, we are having with us Dr. Eknath Kulkarni sir, who is a renowned person in Ayurvedic field, and we had got many awards. I welcome you, sir.
Okay, thank you very much.
Similarly, I welcome all the participants and other respected personalities who have joined in this webinar. And with this, may I request my friend Dr. Ravi Pardesi sir to kindly introduce our today's guest speaker as well as the webinar observer from Maharashtra Institute of Health Sciences, Nashik. Thank you. Over to you, Ravi sir.
Yes, sir. Thank you. Thanks a lot. Good morning, all. This is Dr. Raviraj Pardesi. I am professor in physiology at Jupiter Ayurved College, Nagpur. So I take this opportunity to introduce our today's chief guest, Dr. Nilay Nimbalkar sir, who is a postgraduate in radiology and is currently director of a precision scan and research center, one of the most reputed radiology diagnostic centers in Nagpur. And he has experience of doing cardiac CT and MRI, imaging, CT angiography, body imaging, and CT guided procedures. Apart from this, he is into the academics also. He is holding a PG diploma, teacher for DMRT students at Precision Scan, and is a director and head of the Institute for DMRT courses at Precision Scan. Not only this, he has various publications to his credit. He has written 3 textbook chapters and has been faculty at various multiple conferences. So we have a dynamic personality with us, and he will be guiding us on how we can take help of radiological imaging or X-ray for diagnosing variety of cardiological disorders. I welcome you, sir. At the same time, I would like to welcome our observer, Dr. Eknath Kulkarni sir. I know him as an enthusiastic person whose enthusiasm and dedication is directly proportional to his seniority. He is currently working as a professor in Kaya Chikitsa with Ayurved Seva Sangh, Ayurved Mahavidyalaya, Nashik. And he has over 25 years of experience and is editor of Ayurved Patrika, which is a reputed journal in the field of Ayurveda. He has over 30 research papers and over 250 articles which have been published in various newspapers, national and international journals to his credit. He has received Ideal Teacher Award twice, Dhanvantari and Lifetime Achievement Award, and 12 other awards for medico-social services. He is editor of 4 books. He has guided over 20 PG students, and currently 2 students are doing PhD under his guidance. So I welcome you also, sir. And with this, I hand over stage to Dr. Nilay Nimbalkar and request him to guide audience. Thank you, sir.
I will
sir,
share
you can
my
share
screen
the
now.
screen. Yes, sir. Yes.
Yeah.
Sir.
Thank you. Please let me know if I am visible properly.
Yes,
My
yes,
screen
yes,
is
we
visible. And
we
I am
can see
audible
it.
nice. Yeah.
Yes, yes.
Thank you. Good morning to you all. I am Dr. Nilay Nimbalkar, Director and Radiologist at Precision Scan and Research Center, currently heading the imaging part, predominantly the cardiac, whether it's CT or MRI. My warm regards to Dr. Waghe sir, to Dr. Kulkarni sir, and the dignitaries present here in this webinar. We will start with the CT angio. We will cover it in two parts. One is CT and another is MRI. Why it is so? We have progressed immensely from the age of Nadi Pariksha to the ECG and then coming back to the catheter angiography. Everything has its role, strict role in the present life also, from Nadi Pariksha to ECG to catheter angiography. But in Sanskrit, we have a saying that Nahi jnana samam loke pavitram cha anya sadhanam vijnanam sarva lokanam utkarshaya spritam kalu. So the science is progressing. So we have to progress with the science. So there are innovations coming up in the world of imaging and even that for the cardiac imaging. What are those imaging innovations? We have CT coronary angiography where we actually look at the coronary arteries just like a normal CT scan. Definitely the machines are of higher configuration. The machines are so fast that it can pick up a beating heart like a photograph taken of a fast moving vehicle. We can see the coronary arteries from its origin, how the coronary arteries are seen from the coronary curves, if they are diseased or not, and if they are forming good collaterals with the rest of the vessels, and whether it is supplying the myocardium nicely or not. But the other part, which is a cardiac MRI, we can see the functioning of the heart. We can see whether the myocardium is getting the supply, whether the myocardium is contracting nicely or not. So by CT coronary angiography, we can definitely have good idea about the morphology of the heart and the coronary vessel morphology per se, whether it is obstructed, whether it is having soft plaque, whether it is having calcified plaque. But with MRI imaging, we can see whether the heart is functioning nicely. If all the chambers are contracting nicely, if the walls are seen nicely or not, if they are diseased, whether they are diseased or not, and if diseased, then what kind of disease is present. So in my two lectures, back to back, we will be discussing one about the CT coronary angiography and other, we will be discussing about the cardiac MRI, its functionality and its uses. So it all started with say around 2000 when Times Magazine has published one article about the cardiac CT changing the rules of coronary angiography. That time it was very much hyped that cardiac CT is going to change everything. Cardiac CT is going to replace catheter angiography. But one thing we should keep in mind that cardiac angiography will give us about the anatomy of coronary vessels and minimal functioning of the coronary vessels. It is not going to give us any variations in the flow at particular level of narrowing. And definitely catheter angiography holds the part of being the most accurate method for identifying the stenosis in that particular coronary vessels. These are the beautiful images of beating heart, which is showing that the coronary arteries arising from its origin, passing into its respective places, RCA in the right atrioventricular groove, LCX in the left atrioventricular groove, and LAD in the anterior interventricular groove. If these vessels are properly placed, we have to look at those vessels, whether they are narrowed, whether they are not. Multiple studies have shown that the sensitivity and specificity is increasing day by day. These predominant studies are done on the 64 slice machine, but now we have 128 slice, 256 slice machines, which are faster, more accurate. And the softwares have developed in such a way that we can negate the deposited calcium in the coronary vessels to see whether the narrowing is properly evaluated or not. There are few contraindications that we must know about doing a coronary CT angiography. A patient who is in failure and having heart rate of more than 100, we should not give the drugs which like beta blockers, which we usually give to reduce the heart rate to the desired range. So that is one contraindication. Second is the renal failure, because the contrast what we inject is definitely having some side effects on the kidney. And if the kidney is already in failure, then we might exacerbate that failure. If the patient is having severe contrast reaction history, definitely we should take some time to evaluate whether our contrast is having the similar reaction to the patient by giving a small dose in the subcutaneous layer, and then see whether it is reacting to that contrast or not. And then only we will proceed with the contrast injection. Acute bronchial asthma, if the patient is in an acute stage of bronchial asthma, then only it will be an absolute contraindication. We can wait for some time. We can treat the acute exacerbated asthma first. And if the patient is settled down, then we can proceed with this study. So these are predominant contraindications to go ahead with CT coronary angiography. None of these are absolute contraindication. If there is a need, then we can definitely go ahead with the newer generation of CT scanners, which can give us better imaging even at the pulse rate of 100 or 110. So cardiac failure, without giving any drug, we can still go ahead with contrast injection and get a good scan. Renal failure, definitely, if the patient is not on the dialysis, we will wait for the renal function to recover, or that CT coronary angiographic contrast injection is contraindicated, and severe reaction is definitely an contraindication. So we do few changes in the patient's pulse rate by giving few drugs like beta blockers, which will reduce the pulse rate of the patient in a desired range, which usually we call at 60 to 70 pulse per minute. We can do it by giving ivabradine, which is a new drug, which is a funny channel blocker at AV node, and then still can achieve the heart rate faster than the beta blocker without any side effects of beta blocker like hypertension. So we have multiple medications which we can give and get the pulse rate in a desired range. What is it for? To evaluate the coronary arteries. We evaluate the coronary arteries in two ways. One is to see how much calcium is deposited in the coronary vessels, whether they are deposited in a single area, in a chunk, or they are distributed throughout the coronary vessels at different places. These coronary calcium will give us idea whether the coronaries are diseased or not. If absolutely normal, in a young patient, we can definitely assure them that your coronaries most likely will be normal. And if significant calcification is present in the disease, then we must proceed with evaluation by injecting contrast and see how much the vessels are affected, how much vessels are narrowed, and at what areas they are affected. This coronary calcium score, we have particular data. We compare our scores with those data and say whether this is severe coronary calcium deposit or mild coronary calcium deposit or a minimal coronary calcium deposit. We do scan the chest. If it's a CABG or post-graft patient, then we scan from the root of neck to the base of the thorax, or if it's a normal scan, then from the carina to the base of the heart. So the scanning protocols will change according to the area of involvement, whether it's a CABG post-bypass patient or it's a routine scan. We usually see these vessels nicely, well opacified. We look at the origins of the coronary arteries. So this is RCA passing from the right atrioventricular groove. This is LAD in the interventricular groove. So aorta, left main artery, and this is LCX, which is in the left atrioventricular groove. The left ventricle is nicely opacified. The left atrium is usually nicely opacified, and we want the right atrium and ventricle to be not that well opacified because we wanted to see the coronary arteries as a predominant structure and not the ventricles and its cavities. So once we evaluate that, the coronaries are in its place from the origin to its course, then we can proceed by this volume rendered images to see if the anatomy is normal or not, whether the divisions are normal or not. This is the area of crux where the RCA divides into PDA, the posterior descending artery, and the PLV branch, which goes towards the LCX, and this is the LCX branch. So we can have complete idea of the coronary anatomies by looking at these VR images, which are the volume rendered images. We can have multiple reformations like this globe reformation, which give us idea about all the vascular anatomy in a single go or in multiple images like this, which is giving evaluation of LCX, giving evaluation of ramus intermedius, as well as the LAD, and then the RCA and its branches. We can see the coronary calcium deposited in all the vessels. Still, we can evaluate the vessel lumen, because predominantly it will be the positive remodeling. The calcium will be along its wall and not causing significant compression of the lumen. And we can evaluate the narrowing, how much narrowing it is, whether it's a soft plaque, whether it's a calcified plaque, and whether it is causing severe luminal narrowing at the left main itself or involving the LAD, LCX, or the RCA. The dominance of the site, whether it is predominantly right dominant circulation or a left dominant circulation, that also we can decide on these vessels. We can evaluate the anatomical original abnormalities, like in this vessel, the LCX or the left main coronary arteries arising from the right coronary cusp rather than the left coronary cusp. If a catheter angiography is done for this patient and they evaluate only the RCA, they will not find the left main artery anywhere, and they will keep on searching, poking the coronary sinuses for origin of the vessels. So many a times we may get requisition about ki I am doing catheter angiography, I am looking at the patient, but I cannot see a major vessel and still the patient is normal. How can it be? So we have to evaluate the origin of vessels, and coronary CT angiography is the best modality for that. So with whether the plaque evaluation, calcified, soft plaque, we can nicely evaluate the anomalous origin of coronary vessels, whether from the right coronary cusp or the left coronary cusp. This has a very significant impact in health in the present scenario, because these anomalies are called as malignant coronary anomalies. And without these vessels being diseased, patient may have severe myocardial infarct, because these vessels get compressed between the aorta and the pulmonary artery, and there could be severe narrowing. And if the patient is exercising tremendously, his heart rate is too high, the vessels are dilated, these pulmonary and the aorta may compress the coronary vessel, leading to the MI to this patient. We have seen multiple examples where we feel that the athlete was in a good shape, he was not having any disease, and on one fine morning, while he was doing his jogging and the fast run, he had sudden MI. So one of the possibilities is that he may have an anomalous coronary artery origin, which is passing, which may get compressed with high exercise load and leading to the myocardial infarct in these patients. So this is another example where right coronary artery arising from the left coronary cusp and getting compressed between the pulmonary artery and the aorta. So these are different anomalies where the patient is otherwise absolutely perfect. He's not having any disease. So these could be a cause for his presentation. Then we evaluate the vessels for the calcium deposit, for the soft plaques present, how much is the narrowing, whether it is extending in the peripheral vessels, in the PDA or PLV, as well as rest of the vessels or not. We look at the calcium, look at the vessel lumen, and we can calculate how much percent narrowing is there. Now, it is not only the percent narrowing which is affecting the treatment modality, but there is very important aspect to it, is a vulnerable plaque. So vulnerable plaques are the plaques which are there and which can rupture in a sudden event, leading to embolus in the distal coronary vessels. So the CT coronary angiography is the only modality which can identify whether the plaque is a vulnerable plaque or not. Multiple studies have done and which have shown that there are few cases which suggest that this plaque is a vulnerable plaque. One of these is a soft plaque, which is predominantly a lipid-laden fat. That plenty of fat is deposited at the center of the plaque and having a thin capsule. If that capsule ruptures, then whole of the plaque can just load all the fat into the vessel, which will go into the distal vessel and obstruct the periphery of the vessel. So a soft plaque is a character of vulnerable plaque. Then there are few signs which we identify on CT, one of which is a napkin ring sign, a soft plaque, and a positive remodeling plus spotty calcifications. These are the early calcifications which are happening at the center of the plaque. So all these characters give us idea about the vulnerable plaque. Now, if a CT coronary angiography can evaluate all these things, can it be evaluated on catheter angiography? No, it cannot be nicely evaluated because there are few fallacies in catheter coronary angiography. What are those? Catheter coronary angiography is actually a luminograph. Means it will evaluate the lumen proper, but not the wall. If you are missing the wall, definitely you are missing what characters this plaque is. That's why you are missing the vulnerability of the plaque. So you may get an idea that, yeah, the coronary vessels are affected, but the narrowing is mild. It is around 30 to 40%, so nothing has to be done. And if you do CT coronary angiography in those patients, and what we see is a soft plaque which is lying along the periphery of the wall, which is lipid-laden, which is having all characters of a vulnerable plaque, and there to burst into the vessel to cause occlusion of the distal vessel leading to MI. So characterization of the plaque is having immense role in imaging to identify the vulnerable plaque and then leading to its diagnosis and treatment to stabilize that plaque. The CT coronary angiography is also very useful in identification of the stent, its patency, whether the flow is nice and crystal clear in the vessel distal to the stent, proximal to the stent, whether there is any other disease which is actually causing the obstruction other than the areas which are already put with the stent. So identifying those areas is really important. Evaluation of the stent is really important. We can actually calculate the Hounsfield values within the stent lumen to show that whether the stent is having any disease or not, and whether there is any disease distal to the stent causing significant luminal narrowing. We can evaluate the coronary bypass grafts. Here again, the catheter angiography don't want to intervene because most of the time these patients are having significant plaque load even in the arch of aorta, and they may dislodge that plaque into the periphery vessels. So what we need to evaluate the vessels from its origin to the bypass graft anastomotic sites, and even we can see the distal vessels. We can see the vessel origin nicely. We can evaluate the vessel which is grafted, and we can see the LAD or the vessel which is given the supply through this graft and good distal vessel opacification. So all these evaluations are done without putting up a catheter in the vessel. We are just injecting contrast. We have better machines. We can evaluate from the origin of the graft to the distal vessel and give us the proper diagnosis whether this vessel is diseased or not. We can, if the diseased vessel is put with a stent, we can see the stent in the graft also, and whether there is any further soft plaque formation distal to the stent in the graft vessel. So this is an SVG graft put. It was having some vessel disease. Then we had put the graft in this vessel, which is showing good luminal opacification, and then the soft plaque distal to the graft site. So the VR image is giving better idea about the anastomotic sites, then the vessel evaluation from its origin to the anastomotic site, and then the distal vessel. So it's a comprehensive evaluation, but we may sometimes have difficulties from the clinician perspective, whether the chest pain is from the coronary vessel disease, or it's from pulmonary embolism, or it's a aortic dissection. So we have modalities. In the same sitting, we can do a triple rule out, where we evaluate the aorta nicely. We can evaluate the coronaries as well as the pulmonary arteries in a single contrast injection scan, giving rise to possibilities of dissection in aorta, possibilities of pulmonary embolism, as well as the coronary artery disease, whether it is diseased or not in a single study. And that's a really helpful if unexplained severe chest pain is there and you have ruled out whether it is not having esophageal disease or gastritis. So what we need to do is a triple rule out, which can evaluate coronary arteries, which can evaluate aorta, and which can evaluate pulmonary arteries in a single go. Not all patients are lucky enough to have a natural bypass. Many patients can develop good natural bypass. Now, this is a completely diseased LAD. This is completely diseased RCA, but the God is great and it has given a good bypass graft naturally to this patient by giving a big collateral, which is actually supplying both LAD and the distal RCA, leading to the preservation of circulation in the distal vessel. So if the patient is lucky enough, we are really happy, but simultaneously we have to look whether the myocardium is involved, whether the plaque is there in the vessels which are affected. We can evaluate the multiple walls, the aortic wall, we can evaluate the mitral wall in the same setting. If there are diseases which are present in the mitral or the aortic wall, giving rise to a comprehensive analysis of coronaries, of the wall, as well as the left ventricular lumen in a single study. CT-FFR is a non-invasive technique which is coming up very soon in all the practices where we do the catheter and we do the CT coronary angiography, send the data to the cloud, and then the evaluation comes about the fractional flow reserve which is present. Presently, the catheter angiography is the only modality where we can calculate the fractional flow reserve. But CT-FFR from the HeartFlow and multiple other companies are coming up with the evaluation of fractional flow reserve from the CT images. And that is going to change the modality, whether the patient needs invasion, whether the patient needs catheter, whether the patient needs stent placement or a CABG, just by doing a CT coronary angiography, which is presently lacking, but coming very soon. Maybe within a year or two, we may offer you the fractional flow reserve calculation just from the CT angiography, what we have done at our center, and you will get all the evaluation at your center. So these are the images where we can calculate the fractional flow reserve. This is the narrowing area of narrowing. So fractional flow reserve has reduced to 0.8, and something which is below 0.8 is definitely having low fractional flow reserve, leading to the ischemia or inducible ischemia in the area supplied by these arteries. NICE has given a wonderful guidelines in the recent year, just 2017 to 19. The NICE trial is the biggest trial where they have included CT coronary angiography as a first line test. Before doing catheter angiography to any patient, you must go for CT coronary angiography. And there is a quite strong evidence which suggests that, I will read from the quote itself, with NICE recommending cardiac CT as the first line investigation for all patients presenting with chest pain due to suspected coronary artery disease. Additionally, the randomized control trial have demonstrated that CT cardiac improves diagnostic certainty when incorporated into chest pain pathway. The initial pathway was patient comes with the chest pain, ECG done, ECG showing mild changes, which are whether it's from the old changes, whether it's a congenital abnormality in the ECG or it is the real abnormality. The chest pain complaints are persistent. The patient is not having any gastric related, those areas are ruled out. Then the first line of investigation should be CT coronary angiography before anything else. And that will definitely over 5 years will improve the outcome of that patient. Similar studies are done all over the world. One of the important ones are the SCOT Heart study or the PROMISE study, which has given the same point that CT coronary angiography done in the early stage will give us better idea about the coronary anatomies, with a better idea about the coronary vessel disease and improvement according to those evaluations. So I will just end my this CT angiography talk with saying that modality this CT angiography is the choice for chest pain evaluation. It is given by the NICE trial, and NHS UK has incorporated CT as the first modality to be done in patient with a chest pain. It has excellent depiction of coronary anomalies, investigation of choice for CABG evaluation, stent, and with predominantly which are more than 3 mm diameter. It best identifies the unstable plaque, and the future trends with CT-FFR is a non-invasive technique and will be giving us idea about whether the intervention has to be done for this patient or not. The radiation dose, which is one of the concerns for CT angiography, is reducing significantly with the newer technique, newer imaging machines. The radiation dose has gone down so significantly that we need not to worry about the radiation imparted or given to the patient with CT coronary angiography in the present scenario. So we are ending our first talk, and I will swiftly move to the next talk, which is the MRI of cardiac. Now, CT definitely has radiation, which is given to the patient injecting contrast, and we look at the vessel lumen and not the functioning of the heart. So heart has two aspects we have to evaluate. One is the coronaries, whether they are diseased or not, and second is the function. CT cannot evaluate the functioning nicely. CT cannot evaluate the myocardium, whether their myocardium is getting the supply or not. Now, this is the end organ. Throughout our life, our myocardium is contracting continuously to give the supply nicely to peripheral organs and to the rest of the body. This myocardium is continuously working, and the supply is through the coronary vessels. So we have evaluated the coronary vessels by doing either catheter coronary angiography or CT coronary angiography. But many a times, these vessel pathologies are not giving clear picture about what is happening at the level of myocardium. Whether multiple collaterals have developed and giving good supply to the myocardium, or it is the diseased vessel which is actually causing problem to that myocardium, we have to evaluate it by doing cardiac MRI. Now, is it the only choice? No, we can do plenty of other investigations to see this, and I will talk about that. Evaluation of functioning started with ultrasound in, say, around 1993, then transesophageal ultrasound, then echo, then chest echo, but we have evaluated it by doing some part by ECG-gated CT scan. But MR has revolutionized doing the functional imaging of cardiac. MRI is having magnetic resonance. So the multiple magnetic waves pass through the body, they are reflected from the body, and then they are picked up as a signal. So no radiation, it's only the magnetic resonance which is going to the body and coming back. So that is one of the biggest advantages MRI is having. Second, day by day, the MRI is getting faster and faster, and it can evaluate the functioning organs to the perfection that it can evaluate and see how it is functioning, how the organs are looking by different physical techniques. And we can see the images like this with functioning heart, the myocardium, the chambers of the heart, and how it is contracting. So all these evaluations can be done by cardiac MRI. How do we do that? We have this technique. We just look at the cardiac first by doing black blood imaging, where the blood looks black and only the cardiac anatomy is nicely seen. We can see the pathology, whether the anatomical variations are present, how are the vessels, whether there is any extra vessel, which is an left-sided SVC as well as right-sided SVC. So extra vessel is seen, and then we go for further evaluation of the heart by looking at different axes of the heart. Like echocardiography, we have the similar nomenclature, like 2-chamber view, 4-chamber view, 3-chamber view, apical view, and so this is a 4-chamber view of the heart, where right atrium, where the right atrium, right ventricle, tricuspid valves, left atrium, left ventricle, the mitral valve, origins of pulmonary arteries, origins of aorta are nicely evaluated. We have different planes like this, which is a short axis view coming from the base, mid cavity of the heart, and the apex. And we can see the functioning contractility, whether there is any abnormality in the contraction of any of the chamber walls. We have divided into anterior, inferior, lateral, and the septal segments of the heart. So we can see complete anatomy, the 17-chamber heart view in a single go with 4-chamber. So now can you see the difference? This part is significantly thinned out. This is a normal thickness of the myocardium. This is mildly thinned out myocardium, but the anterior segment of the mid myocardium is significantly thinned out. The septal segments are thinned out, and it is not contracting properly. What is the ideal contraction during the systole? The myocardium should get thick and move toward the center of the heart. Here, it is moving away from the heart. So there is area of dyskinesia which is present along the septal myocardium as well as the anterior myocardium, and the thinning of the myocardium, suggesting that insult is there, which has caused significant thinning of the myocardium and functional abnormality with dilatation of the chambers. So we can see all these dilatation, thinning in these trophy images, which we call, which are the cine images. Different machines have different names. And these images can give us idea about the functioning. We can see the mitral valve opening, whether it is opening nicely, whether it is completely closing up, or there is any evidence of regurgitation or stenosis in this mitral valve. So we have evaluated left ventricle, we have evaluated the right ventricle cavity, whether it is contracting nicely or not. And in a single go, we can get idea about the functioning of the heart. This is another example where we are tracking from the apex of the heart, then going to the mid cavity and to the base of the heart. The papillary muscles are nicely seen. The contractility is nicely seen. The RV is nicely evaluated. And then coming to aorta and the pulmonary artery in a single go. We have different techniques to see whether the myocardium has edema, which are the titulated images, the stir-like images, what we call, which gives us idea about the myocardial edema, which is present, whether there is hypertrophy of the myocardium, which is one of the causes of sudden cardiac arrest, the hypertrophic cardiomyopathy causing obstruction of the left ventricular outflow, or vessel passing through the hypertrophic myocardium getting compressed in a tunneled coronary vessels. So all these areas can be evaluated. Myocardium thickness can be seen, whether this is hypertrophic, whether the myocardium is having edema and it is having normal anatomy or not. We can see functioning of the valves. This is a 2-chamber view where left atrium and left ventricle is evaluated, and you can see the inferior valve is not contracting nicely. Even there is some dilatation in the apical segment of the heart and some thinning, significant thinning in the apex of the heart. Similar ways, this is a 3-chamber view, which gives us idea about the aortic outlet. And if I show you this, the anterior mitral leaflet is actually causing some obstruction here, giving rise to a jet. And this is significant aortic stenosis happening, causing a big jet and not clear opening of the aorta. So all these anomalies or the abnormalities can be nicely seen. This is the left ventricular outflow tract. This is the right ventricular outflow tract, the pulmonary valves, the aortic valve. So we can evaluate whether there is any regurgitation. We can evaluate whether there is stenosis and what is happening at the myocardium. Now there is another important aspect, which is actually very challenging for many people, because we have to see whether the heart is having inducible ischemia. The heart is functioning absolutely in a synchrony with the rest of the organs when the heart is in rest position. But as soon as you give heart some trouble, the heart starts pumping fast. You are exercising, the heart is pumping fast, and then the chest pain starts. So that is the inducible ischemia, because the coronary vessels at rest are giving enough supply to the myocardium. But as soon as the myocardium is asking for more blood, the supply is not good enough. So that is called as inducible ischemia, and we can evaluate it with stress cardiac MRI study. So what we do, we cannot have a treadmill in the MRI machine. So we inject adenosine to this patient and give signal to the heart in such a way that as if the body is doing exercise. And what we look at by injecting contrast, that the myocardium is getting the supply nicely or not. So the normally enhancing myocardium looks like this, but the black line suggests that the supply of blood in these areas are not good enough. So this is a stress cardiac scan. And how do we evaluate that? We inject the contrast, we give stress to the patient, and we see whether the myocardium is getting supply or not. So this is a normally enhancing myocardium. Look at this. It is enhancing nicely, but some part of the myocardium is not at all enhancing in the first part. So the septal myocardium is not at all enhancing at the basal level. Even the anteroseptal myocardium in the mid cavity is also not getting the enhancement in proper. So we can depict that myocardium in these areas are not getting the supply, and we can evaluate that by the late gadolinium enhancement scans, which will suggest that these enhancing areas are actually the infarcted myocardium. So whether the vessel has to be opened up or not, decision making decides on these scans. So now if you have a vessel which is nearly 80 to 90% obstructed, say LAD or LCX, and now the patient comes for the stress cardiac MRI imaging or the viability imaging, and we see that this area, the LCX area, is absolutely gone. There is no viable myocardium remaining here. So it is all fibrous, it is all infarcted. So now there is no point in going ahead with opening up of that vessel. There is no point in grafting that vessel with the bypass graft, and there is no point in stenting that vessel, because it is not going to supply any of the viable myocardium. And if you open up that vessel, then there will be complications like hematoma, rupture, and even the collection in the pericardium in these cases. So before stenting, before opening, if it is not an acute event where you can salvage the myocardium, if it has happened somewhere bad, then definitely you have to take a call, have to send these patients for viability scan and then get it evaluated. Now, what are the advantages the CT or the MRI is having over rest of the viability scans? What are the options we have for viability imaging? One is thallium scan, which we evaluate for so many years. Thallium gives us idea about the viability. Then the MRI, then PET scan. So present scenario, PET scan for cardiac is supposed to be the gold standard. But both thallium and the PET scan has disadvantages. One, it has significant radiation dose to the patient. And second, it has its own lacunae. What are those? First, we will discuss about the thallium scan. If we are going to inject the thallium, first and the foremost thing, that exercise has to be done during the post-thallium evaluation for the stress cardiac MRI. Thallium has a sensitivity of say around 60 to 70% for evaluating the myocardium. This is for a general group. And if you have female patient, then definitely because of the anterior chest wall soft tissue, which are bigger than the male chest, the thallium is going to reduce its sensitivity significantly in those cases. Now, who are the people who will be going for thallium scan or the viability scan? Predominantly, these are the people who are above the age of 60 or 50 nowadays. if these patients, we put them to a stress, are they really going to achieve that particular stress level on a physical stress machine or a treadmill scan? It is virtually impossible for a 60 to 70-year Agrawal lady to do a stress scanning or do an exercise on the treadmill for 10 minutes to achieve the level which is required. So there are plenty of disadvantages and the sensitivity is down. Now, MRI cardiac is done in a cardiac machine, MRI machine, and we don't have to put them on a stress. That is one. We can negate the anterior chest wall soft tissue very easily. We don't have any issue with that because MRI is a three-dimensional imaging. We can do it in axial, coronal, sagittal, in any ways, and we can have all volumetric data in a single copy. Plus, we evaluate the heart in 3 to 4 categories. Now, what are these categories? We see the functioning and thinning of the myocardium. We inject the contrast and see whether there is any perfusion abnormality. We put them on stress to see whether there is any inducible ischemia. We have late gadolinium enhancement scan, which gives us idea about the fibrosis or the infarct, which is virtually impossible with rest of the scans. So definitely PET is the gold standard, but immediately to the PET, CMR gives us the best results, and that too without any radiation to the patient. So what are the stress studies we do? We take normal scans, we inject the adenosine, do the stress cardiac MR, then do the rest cardiac MR, and then what we see. So this is a stress scan, this is a rest scan, and what we can see that definitely there is blackening of the septal myocardium here, which has reduced significantly on the rest scan, and the anterior myocardium at the basal segments, which is not seen on the rest scan. So by putting the patient under stress and rest conditions, we can evaluate whether the patient is having inducible ischemia or not. Now we know which territory is supplying these cardiac segments, like anterior myocardium and the septal myocardium by LAD. And if the CT coronary or the catheter coronary angiography is showing that there is vessel disease in the LAD, there is vessel disease in the LC, there is vessel disease in the RC. And if you want to just stent one of the vessels, which is really important, then that vessel will be the LAD and not the L6 or the RC. So by evaluating stress imaging, we can see whether there is any wall motion abnormality in a pictorial way. The gadolinium enhancement will give us idea about the infarcts which are present, and hence we can depict which myocardium is viable and which myocardium is not viable in our report. We simultaneously see whether the myocardium is abnormal by some of the deposition diseases or hypertrophic cardiomyopathies or dilated cardiomyopathy. We can evaluate the fibrosis because these are the areas which will give the patient the ventricular tachycardias, which is really important for the prognostic matter. And we can see this in the same study, whether the patient is having hypertrophic cardiomyopathy, which part is involved, whether the outflow tracts are obstructed, and how much is the fibrosis present in hypertrophic cardiomyopathy. We can see different substrates where the arrhythmias are happening. We can see the ARVD, that is the arrhythmogenic right ventricular cardiomyopathy, whether it is associated with the left ventricular cardiomyopathy, whether there is dilatation of the chambers, and all this evaluation can be done in the same MRI sitting. What is really helpful, by putting up a bit of 1 or 2 ml of contrast, additional to that, we can evaluate the anatomy of the thoracic vessels, pulmonary as well as the aorta, which is really helpful in few cases. We can calculate the ejection fractions in the same sitting, and MRI ejection fraction calculation is the gold standard for evaluation of the heart functioning, even better than echocardiography, and giving rise to perfect evaluation of the heart, evaluation of the percentage of fibrosis which is present, and many a times we can see the flow parameters in the aorta as well as the pulmonary artery. We can calculate these vessel velocities and giving rise to different analysis of abnormalities in these vessels. We can evaluate whether there is any tumor, whether the thrombus is present or a tumor, whether the infarcted myocardium, and how much is the thrombus present along its wall and in the cavity, and all these evaluations in a single core. Myocardial and the cardiac tumors can be evaluated in a similar manner. And then one of the most important evaluation in thalassemia patients, how much iron is deposited in this myocardium, that also can be done with MRI imaging. So it's basically a comprehensive imaging technique. And with the newer advances of T1 and T2 mapping, what we called as a multi-parametric imaging, with T2 star giving iron overload, T1 and T2 mapping will give us idea whether the fibrosis which has happened is because of infarct, or whether it is because of some deposition diseases, whether this is because of the amyloidosis, by just taking the T1 and T2 maps and the ECV maps, and we can have complete comprehensive idea about the disease process which is given. So in nutshell, CMR is the future of cardiac imaging. We will be evaluating the myocardium pathologies to the perfection with CMR imaging, that is cardiac magnetic resonance imaging. Thank you.
So thank you, thank you, sir. So if you allow me to ask some questions.
Yeah, please.
Yes, sir. One of the slides was showing the development of collaterals.
Yeah.
So was that collateral originating directly from aorta there, as I could see in the slide?
RCA basically. It was just from the RCA. The proximal RCA, that collateral was arising, and then it was giving supply to the distal LAD as well as the PDA. Because there was significant disease in the proximal RCA too, and we were worried how that myocardium is not infarcted. It was predominantly because of the large collateral which was present.
And what percentage of patients you see having collaterals on day-to-day basis?
Such a large collateral are rare to found. Definitely catheter angio will pick up collaterals much in a better way. But definitely we see for chronically diseased vessels, we can see plenty of collaterals. And that is one of the part of evaluation, whether the vessels are getting collateral supply or not.
Yes, yes, sir. And that contrast-induced toxicity or nephrotoxicity. Yes. Yeah. How long it can last? Is it reversible in all cases?
Predominantly, it is reversible. It is not that common. With a newer contrast agent, that has reduced significantly. And now, before doing any CT angiography, we usually go for eGFR calculation. And if the eGFR is predominantly above 30, we don't find much complications related to contrast-induced nephropathy. It is predominantly the patient who is already in nephropathy. We should not give contrast. If already he is in some kind of disease by renal function abnormalities there, then we should not immediately inject contrast. We should wait for that function to recover, and then we can definitely inject. So we don't want to have additional pressure to the kidney. That's it.
Yes, sir. Yes. You spoke about visualization of a calcium deposition, atheroma. Yes. What about thrombus? Thrombus?
So the thrombus is the same thing, atheroma, plaque, and then the evaluation of the thrombus in 2 or 3 different, whether it's a soft plaque, whether it's a hard plaque, or whether it's a fibrofatty plaque. Then nowadays we have a significant evaluation of those areas. If you allow me, I can show those slides also.
Yes, sir,
where
please.
We can actually calculate what percentage of plaque is fibrous plaque, what percentage of plaque is calcified, and what percentage of plaque is fatty plaque. Do you want me to show those images also?
Yes, yes, sir.
Just give me. Just Is my screen visible?
No, it's not visible.
Yeah. Start that. So these are the, is it visible now?
Yes.
Yeah. So this is a slide which shows us that what kind of thrombus is present. Now each and every plaque is having different HU values. And according to those HU values, we can actually calculate what HU value plaque is present. So calcium has having something like HU value of more than 600. Type 2 plaques, which are usually the fibrofatty plaque or the fibrous plaque, is having HU value of more than 130. And whatever is below that will be the soft plaque, which is having HU value of say around less than 130. We can color map them. We can show them how much percentage is present, and we can actually calculate volume of that plaque and giving it for the follow-up scans. So if a patient takes treatment for say 3 months, diet modification, lifestyle modification, some drugs on to reduce the plaque size and to make the plaque more stable, we can see those changes in the follow-up scans of the patient, and we can now directly compare length to length.
Achha.
So LED from say around 10 centimeter of LED evaluated initial scan. We repeat the scan after say around 2 to 3 months post treatment, and we again evaluate the same length of the LED and see how much percentage of plaque modification is done. Whether the plaque has gone from the soft plaque to the fibrous plaque, which is a good thing, and then from the fibrous plaque to the calcified plaque, which is a more stable plaque rather than a bad plaque causing more obstruction. So plenty of patients may be refractory to the treatment. Some may respond wonderful to those treatment modalities and can show us that there is significant conversion of soft plaque into fibrous or a calcified plaque, which is a definitely a better plaque to have rather than a soft plaque which may rupture at any time. So these are the imaging, and we have those softwares with us where we can evaluate actual percentage of plaque, what kind of plaque these are, and how much narrowing they can cause.
Yes, sir. Thank you. Thank you, sir. One last question from me. As radiology is advancing in diagnosing variety of diseases to the most precise extent, so do you foresee any future that radiology or interventional radiology will enter into the therapeutics also as far as cardiological intervention is concerned?
Actually, therapeutic, rather than just into therapeutic, basically the evaluation part will only increase. Right now, the CT-FFR will change the role because CT-FFR is going to come very soon. Presently, the catheter has to be put in to calculate the FFR values, and it should cross the stenosed vessel to calculate fractional flow reserve distal to the vessel. But if the stenosis is so tight that they cannot negate the catheter distal to the vessel, then there will be less evaluation of the vessel distal to the stenosis, which we need to calculate. And that is only possible with CT angiography evaluation with FFR. And maybe in a year or two, definitely that is going to come. And then we will have CT FFR calculating and giving idea about whether that vessel has to be stented or grafted. And that definitely, that much part, definitely CT is going to play, not beyond that. Nobody is going to put any stent through CT, that's for sure.
First of all, let me congratulate respected Nila Nimbarkar sir for this excellent and wonderful presentation of the subjects, and with those beautiful pictures and beautiful videos. Through this webinar series, we are coming across and to the various newer technologies, and we are adding to our knowledge. The other day when we conducted on echocardiography, that time we came to know about the spectral echocardiography, a new modality. It was altogether new for us from conventional echocardiography. Then in the talk on coronary angiography the other day, we came across this fractional flow reserve concept on CAG. And now with in today's lecture, that concept is further elaborated by Nila Nimbarkar sir, that even with a I was amazed to see that even with the city angio, that FFR can be calculated with those and in which of the proximal or distal areas the flow the pressure has decreased. The other thing, my friend Ravi was curious to know the other day whether the collaterals can be visualized with the CAG, and now today Dr. Nimbalkar sir has pointed about the natural bypass that is in the form of collaterals that can be visualized on the CT angio also. Now more and more people, they are going for the non-invasive techniques because of the concern for the complications and the contraindication issues therein. But again, when we talk of a CT angio, some of our peoples are having concern with the accuracy of and the precision of the CT angio as compared to the conventional angio, and the other concern about the dose of radiation. And hopefully, as told by Nilay Nimbalkar sir, the MRI angio would be the better option, and this technique, which is in evolution, will be the choice of investigation in years to come, I suppose. And the technology is growing just leaps and bounds. Every day there is change, and God only knows how far we have already reached to the zenith, and how we will be crossing that also. So before actually going for the formal vote of thanks, I would like to invite Dr. Eknath Kulkarni sir for his expert views and as a MUHS observer. So I invite you, sir, to say a few words about our today's program.
Hello. Hello. I'm audible?
Yes, sir, yes.
Okay. Respected Dr. Kalidas Chauhan, Registrar of the Maharashtra University of Health Sciences, Dr. Shrikant Deshmukh, Dean of the Faculty of Ayurveda, Maharashtra University of Health Sciences, Dr. Subhash Waje, Principal of the Jupiter Ayurveda College. I think he is another Dr. Subhash Ranade in the creation of books. So he is also a very learned writer in the field of Ayurveda. Mrs. Tarini Nikhare, Dr. Raviraj Pardeshi, and today's speaker, Dr. Nilay Nimbalkar. I congratulate the Hrudaya Lokana National Webinar Series on cardiac investigative procedures and the Jupiter Ayurvedic Medical College, Nagpur, and Rog Nidan Vikruti Vigyan PG Association. I appreciate the efforts taken for the successful organization of this webinar. Ayurveda has written in his text that Darshana Sparshana Prashnaihi Parikshetacha Rohinam Rogam Nidana Pragrupa Nidanopashayaptibhi. So, radiological investigations is the modification of Darshan Pariksha in Ayurveda, and Dr. Nilay Nimbalkar has given the very beautiful account of the importance of cardiac investigative procedures, that is cardiac angiography, CT angiography, and CMR, that is cardiac MRI. These two investigations are very important, and they are advancing, and they are very useful for the treatment of cardiac diseases, diagnosis and treatment. And newer advances are also spoken by Dr. Nilay Nimbalkar. Most of the practitioners only read the reports of the radiologist given, but all the practitioners should know the basics of these investigative procedures so that they can do proper diagnosis and proper treatment. So I request all the practitioners to update themselves by listening and participating in such type of webinars. And I congratulate again for the organizers, especially Dr. Subhash Vaje and his team. Ayurveda is beyond these all investigative procedures. In Ayurveda, it is written that Jnana Buddhi Pradipena Yona Vishati Tattvavit Aturasya Antaratmanam Nasarogam Chikitsati. So these investigations are good, but the physician, the practitioner, should use his knowledge and interpretation of all the investigative procedures, and by the lamp of the knowledge, he should enter the antaratmanam of the deceased person or the patient, and then he can diagnose and treat the patient properly. So ultimate, the sukhavapti, happiness of body and mind is the ultimate aim of the Ayurvedic treatment, and we should all be able to interpret all these modern investigations, but we should always keep the advice given by our rishis for the treatment of diseases. So on this occasion of World Heart Day, Jupiter Ayurvedic College has organized a good seminar, good webinar, and I am very thankful to the university for appointing me as an observer for this webinar. I am very thankful to Dr. Subhash Vaje and all the team and the speaker, Dr. Milan Nimbalkar, for giving me a good knowledge gift on this occasion of this World Heart Day. I also congratulate all the listeners offline and online for this national webinar. Thank you very much. Sarvetra sukhinas santu, sarve santu niramayaha, sarve bhadrani pashyantu, ma kaschit dukkham apnuyat. Thanks a lot. Dhanyawad.
Thank you, sir. Another beauty of the today's lecture was which I forgotten to mention, that the composition of plaque. Composition of plaque by radio diagnosis was an excellent concept that we can notice. Before finally moving for the vote of thanks, I would like to hear Dr. Pradeep Avade sir from MUHS is also here, who is instrumental in giving us the recognition for this webinar series from university side. So may I request Pradeep Avade sir to please come forward and bless us with a few words of blessings.
Yes, after nice words of Eknath Kulkarni sir and the wisdom by today's faculty, I should not say any word right now. But yes, our entire team of this Jupiter Ayurveda College, including Subhash Vaje sir, they are taking very keen efforts for the dissemination of knowledge, which is the objective of the university. So creation, preservation, and dissemination knowledge, these are the objectives of Maharashtra University of Health Sciences, Nashik. And with this integrative approach lecture series, where all top cardiologists are here to share their knowledge regarding various aspects of heart diseases on the World Heart Day occasion. So in a nutshell, I will come again on last day where because I am observing all lecture series and I will give my entire comments on the last day. So with brief my words, I will thanks to all organizers for giving me opportunity to speak. I should also thank to our today's University Observer, Dr. Eknath Kulkarni sir. Over to you, sir. Thank you very much.
I am very thankful to Dr. Pradeep Avale sir also, because he has given me the opportunity for this wonderful webinar. I am very thankful, and thankful again to all the organization. The question answer session was also very good. So it is very knowledge adding webinar for the practitioners, teachers and students. Thank you.
So now may I request my friend Dr. Raviraj Pardesi sir to say, extend a formal vote of thanks.
Yes, sir. Thank you, Nila Nimbarkar sir. Thank you for being with us, and thank you for talking on much needed topic. And we expect that you will be available whenever we request you to be there to deliver a talk on such topics in future also. I thank Dr. Eknath Kulkarni sir, Dr. Pradeep Avale sir, and our principal, Dr. Waghe sir. And the activity is going to be continued for 2 more days. So I request all the audiences again to join the webinars. So with this, with the permission of principal sir, I will call this webinar as over. I thank you all. Good day. So you all may leave now. Sir, if you want to add anything, you can. Waghe sir.
So just I'm very thankful to Dr. Nila Nimbarkar sir from bottom of my heart, and hopefully sometimes we will be calling him.
Yes, yes,
physically.
Yes.
And, he's such a nice personality. We all would like to meet him personally. Thank you, sir.
Thank you.
Thank you, sir. Good day. Thank you. Yes, namaskar.